Morning.
Morning.
So we'll wait a couple of minutes to see if some other people show. But what my plan is for today is I'm going to go over a little bit of stuff with you to get you ready for your fundamentals proctored. Um, so I don't think that'll take the whole time. And then after we're done with that, we'll go ahead and do a little bit with our final so that you guys feel a little bit better about that. So I figured out how to change my background on here. Did you guys see that? There's all these different backgrounds you can put. I don't know if you guys can do this too or not. You should try it. It's kind of cool. Can you guys see what I just put on the screen?
Yeah.
This artificial eye stuff?
Yeah.
Okay, perfect. Just want to make sure I had the right thing up there. So while we're waiting for a couple other people to come in here, do you guys remember on your last fundamentals proctor test, did you have some weird question about how to take care of an artificial eye?
I honestly don't remember.
Because I know in the past I've talked to students after they've taken it and they're like, what the heck? We've never went over that. And it's not really anywhere in the books or anything like that. So I just wanted to pull this up just in case you would get something like that. I don't really have the ability to look at the proctor test to see what's even on it. They don't let us look at it. So I can't really, speak to whatever's going to be on it, but it should, mainly be stuff that's in your fundamentals book. But anyway, I just wanted to go over this in case you would ever get something like this. So when someone has an artificial eye, like it could be a glass eye or made of something else, I know in the past they were saying in that question, it was something about how you should clean it or how you should take care of it, something like that. So when you're looking at this, it's talking about, let's see, here we go, about cleaning it here. So it says you have to use gauze or a tissue soaked in cooled boiled water to clean away any discharge on your eyelids or your eyelashes. Use warm water and mild non-scented soap to wash your artificial eye. So you don't want to use anything special. Rub the eye gently with your fingers, but make sure you don't scratch or drop it. Rinse the eye thoroughly using sterile water before you refit it. So sterile water. And then you have to make sure you get all the soap off and stuff. So I don't think you'll have any kind of questions like how you take it in and out, like how you take your artificial eye out and put it back in. But like this talks about all of that too. So apparently there's some kind of tool right here that they use to get it out with. Um, it's just crazy, but I guess some people have to do that. So we need to learn how to mess with it.
On the ATI site, I was doing some of the proctor the test exams,
Yeah.
and it did have a question on how to put it in and take it out, and it was something about like grab the bony prominences or lift up the eyelid with your forefinger, and but
Yeah.
it did have a question about how to take it out and how to put it in.
Okay. So it's kind of crazy, right? You never would think you would get a question like that. But anyway, so you always want to make sure your hands are nice and clean. They tell you to look in the mirror. For this one on this site, which I don't know what's this called, National Artificial Eye Service. So for this one, this person actually has a tool that they're using to help get it out. But like I guess you don't have to have a tool. You can just use your fingers to get it out if you do it the right way. So anyway, so you have to pull down on your lower lid so you can see the lower edge of the artificial eye, and then you would try and like kind of pop it loose from the lower edge of the eye, and then you gently like pull it out. For putting it back in, you have to lift your upper lid with one hand to make room for your artificial eye. Hold your artificial eye in the other hand. Make sure you have the eye the right way around. And then usually the most pointed end fits near your nose. So push your eye gently under your top lid until it reaches the top of the socket. And then this kind of tells you a little bit too. So hold the eye in that position with the finger of the hand you're using to hold your upper lid. This stops the eye from falling out. Using the free hand, gently pull down your lower lid and the bottom eye will slip easily inside. Hold the eye in that position with the finger of the hand you're using to hold the upper lid. This stops the eye from falling out. Using your free hand, gently pull down your lower lid and the bottom of the eye will slip easily inside. So anyway, that's kind of how you mess with that. So just to be aware, you may have something like that. So make sure you're looking at that information because that might help you. You never know. Okay, so some other stuff I wanted to do with you. See if I can share what I want here. All right, let me see if I can get this other one up. It's this one. Oh, that's not the right one. Hold on. What do you guys see on your screen right now?
You have Nurse Labs up right now.
Oh, so okay. I have two screens and I'm still seeing the eye stuff. So I'm like, wait a minute.
Actually, we never saw any of the eye stuff, so I was just listening to you.
Okay. Well, let's go ahead and do this Nurse Labs thing. So on Nurse Labs, which I'm sure a lot of you have been on here before, when you go up to the top of the page, there is a little menu here that says care plans, exams, study notes, career, nurse life, and news. So go under exams, and then you have to like really page down a lot because there's a ton of stuff on here. But they have all different kinds of exams on here. So like you could practice on everything under the sun on here. So anyway, more towards the bottom, I guess you could say, there's one that says fundamentals of nursing. So that's what I wanted to do with you. So on here, if we click on one of these, it'll pop up and it'll say, when you page down here, there's exam mode, practice mode, and text mode. So I'm going to do practice mode so we can see rationales for things. And then we're going to hit start. So I want you guys to unmute yourselves and try and answer some of this for me so I know which one to pick. So the most important nursing intervention to correct skin dryness is?
D maybe? Well, hold on. I don't know. I'm gonna guess and say D because it says fluid intake and stuff like that. But the lotion thing confuses me. But I think it's D.
Did everyone else agree or no?
After reading them all, I would have chosen D as well.
Okay.
Yep.
So you're correct. So I get what you're saying about the lotion because a lot of times they'll tell you not to do lotion on people. But in this question, it says to correct skin dryness. So if they do have dryness, and it's not saying, to put it on their feet and in between their toes or anything like that, because we all know you're not supposed to do that. But if you're just putting it like on their legs or their arms or something, that's totally fine. There's nothing wrong with that. Okay, so number 2 says, when bathing a patient's extremities, the nurse should use long, firm strokes from distal to proximal areas. This technique does what?
Well, I don't want to answer every single one, but it's I'm thinking C, maybe D.
I would say
C.
D.
So, well, let's think about this for a minute. So why would it cause vasoconstriction?
Oh.
And if you have vasoconstriction, does that increase or decrease your circulation? Right?
Right. So
probably this one.
C.
Okay, vivid dreaming occurs in which stage of sleep?
Rapid eye movement, I think.
You guys agree?
Yeah.
And if you have your ATI book out, you feel free to get it out and take a look, because you have a sleep chapter in there. Okay, how about this one? This is kind of interesting. The natural sedative in meat and milk products, especially warm milk, that can help induce sleep is?
Is that C?
I think so, yeah. So when you're looking at this, this is a medication. This is a sleeping pill. And then your other ones, I don't know what all of these other ones are. Here, what's it say down here? Oh, I guess all the other ones are hypnotic sedatives as well. So typically like that PAM is your ending that would be, tell you it's a hypnotic. Okay, nursing interventions that can help the patient to relax and sleep restfully will include all of the following except
D.
What do you guys think?
Well, I'm thinking if they take a nap in the afternoon, they won't be able to sleep at night, maybe.
Okay.
B.
B.
So, yeah, I guess B, yeah.
So it is A. So napping in the afternoon is not conducive to nighttime sleeping. So quiet music, watching TV, reading, and massage usually help relax the patient, helping them fall asleep. Okay, restraints can be used for all of the following purposes except to what?
Definitely D.
D.
Yeah, I would think so, right? Okay, which of the following is the nurse's legal responsibility when applying restraints?
D.
D.
Yeah, so you have to do all of these things,
D.
definitely. All right, how about these Kubler-Ross's 5 successful stages of death and dying?
B.
Yeah, B looks good to me too. Nope, never mind.
All right, so you're pretty close though. See, there's just a slight difference. It's just these two were mixed up. Okay. A terminally ill patient usually experiences all of the following feelings during the anger stage, except
B.
numbness. So this down here, it says numbness is typical of a depression stage when the patient feels a great sense of loss. The anger stage usually has rage, envy, resentment, and the patient questioning, why me?
How'd you
Well, that's
have
true
envy?
because they're envious of people who are living.
Yeah, yeah.
That makes sense.
Okay. Nurses and other healthcare providers often have difficulty helping a terminally ill patient through the necessary stages leading to acceptance of death. Which of the following strategies is most helpful to the nurse in achieving this goal?
D.
I think this is a hard one. Is it? What's the
Well,
rest do you think?
I mean, I'm floating on C, but I don't know.
I think D.
Okay, well, let's try D. So Brandon, you were right.
Yeah, but I wasn't committed.
So let's read what it says. So according to thanatologists, reflecting on the significance of death helps to reduce the fear of death and enables the healthcare provider to better understand the terminally ill patient's feelings. So the reason I don't think it was the cultural thing is because look at what the question says. It doesn't really say anything about anything cultural. So it wasn't really focused on that. So that's why I wouldn't have chose that. Okay, which of the following symptoms is the best indicator of imminent death?
D, right? The death breathing or whatever they call it. Maybe.
Everyone else agree or no? I mean, you're going to see a few things. It's not just going to be one thing.
I'm trying to think of all the patients I've seen die.
All right, well, let's see if it's right since no one else is saying anything. So fixed dilated pupils. So this means imminent death. So usually you will get a slow pulse. So pulse may become weak but rapid, so it's not going to be slow. Muscles become weak and atonic, so you're not going to have increased muscle tone. And periods of apnea occur during respiration. So you don't always have slow, shallow respirations. You'll have what they call Cheyne-Stokes breathing. Cheyne-Stokes breathing is where they'll have this big long period of apnea and then all of a sudden they'll go and it's just like very scary to watch. Like they breathe super slow and they have these big periods of apnea in between. Okay, so nurse caring for a patient with infectious disease who requires isolation should refer to guidelines published by.
C.
Yeah, B.
Okay,
Unless it's a trick question. Oh.
you got it. Let's see. To institute appropriate isolation precautions, the nurse must first know the.
Mode of transmission.
Yeah.
Okay. All right. What is the correct procedure for collecting a sputum specimen for culture and sensitivity? These are funny.
Is it C?
Yeah, I would think so. I just think it's funny because read what some of these say. Have the patient expectorate the sputum while the nurse holds the container. So you're standing there all day holding the container until they can get the sputum in there. I mean, come on. It's funny. Okay, so let's see. I think it's that. Yeah. Okay, so an autoclave is used to sterilize hospital supplies because.
It's got to be B or D. Maybe D, pressurized steam penetrates the supplies better. Because I know it's like hot steam.
Anyone else know this from where you work or anything? All right, so you're guessing D, Brandon?
Yeah, sure.
Oh, look at you. You're a good guesser.
Got me through this far in life.
Okay. The best way to decrease the risk of transferring pathogens to a patient when removing contaminated gloves is to do what?
C.
Yeah, I'm gonna agree. I think C.
Yeah. Oh, come on. Let's just wash our gloves before we remove them. It's funny. Okay, how about this one? After having an IV line in place for 72 hours, a patient complains of tenderness, burning, and swelling. Assessment of the IV site reveals that it's warm and it's, I can't say it, erythematous, which is red, basically. This usually indicates what?
Phlebitis.
Yeah. So the whole thing here and why it wouldn't be infiltration is because of the redness and the warmth. Because remember, infiltration, you would have swelling and you would have like a coolness at the site. Okay, so to ensure homogenization, when diluting powdered medication in a vial, the nurse should do what?
B.
There you go. Yeah, so they don't want you to shake it vigorously. That can break down the medication and like make it not work the right way. So just rolling it's the best thing to do. All right, this one says the nurse is teaching a patient to prepare a syringe with 40 units of U100 NPH insulin for self-injection. The patient's first priority concerning self-injection in this situation is to what? What would be your first priority if you were giving yourself insulin? What's your first priority to do? What
B.
was- Select the appropriate site. They're saying check the syringe to verify that the nurse has removed the prescribed insulin dose. Oh, I guess if they're saying that you're handing it to them or something, I guess you would want to make sure you have the right dose. That makes sense, I guess. What's this say? When the nurse teaches the patient to prepare an insulin injection, the patient's first priority is to validate the dose accuracy. The next steps are to select the site, assess the site, and then clean the site with alcohol before injecting. All right, here's a math problem. I don't know if you guys have paper or anything. See if you can do this real quick. This is a drops per minute problem. So the order is administer 1 gram of Ansef in 150 milliliters of normal saline solution in 60 minutes. What's the flow rate if the drop factor is 10 drops? So remember, it's your volume times your drop factor over your time in minutes.
Is it A?
Yep, you got it.
Wow, good job. I had no idea.
So remember, we would take 150 times 10 divided by 60. All right, so then we've got another math, it looks like. So a patient must receive 50 units of Humulin R. The label reads 100 units in 1 milliliter. How many milliliters should you administer?
A.
Here we go. And then how should the nurse prepare an injection for a patient who takes both regular and NPH insulin?
B.
Which one?
B.
A.
Which one's
You
correct?
do clear first. You do clear first, which is regular, and then the cloudy, which is MPH, I believe.
Are you sure?
I think it's A. I don't know, but I think it's A.
Yeah.
I always remember it was
I
like
thought
cloudy.
it was right. Cloudy before clear, which is
Yeah,
the NPH.
cloudy,
So
clear. And then, yeah, it's cloudy, clear, clear, cloudy.
I don't know. A.
So
It's B.
I thought it was clear cloudy.
I remember it as RN, regular
Yeah.
Yeah,
NPH.
there you go. Yeah, this is always going to be a question, you guys, so you have to get this straight in your head because it's always a typical question on something. All right, a patient has just received 30 milligrams of codeine by mouth for pain. 5 minutes later, he vomits. What should the nurse do? Don't you love this? Explain to the patient she can do nothing to help him. That's comforting, right?
Sorry, patient, you're on your own. I mean, call the physician, right?
Is that what everyone thinks?
Because you can't remedicate the patient because they might have absorbed some of it. I mean, you can observe the emesis, but I don't think that's really going to do anything. Oh, never mind.
So sometimes if you give someone a medicine and they vomit, sometimes you'll actually see the medicine in the vomit. So you know that it didn't absorb, you know? Like there's certain things that you give, like potassium's one of them. Potassium, people don't really absorb that really well. And so if they vomit, you'll see the actual pills in it. So this is saying you have to inspect the emesis to document the color, consistency, and amount. In this situation, the patient recently ingested the medicine, so that you need to check for remnants of the medication to help determine if they retained enough of it or not. Okay, so a patient is characterized with a number 16 indwelling urinary Foley catheter to determine if, that doesn't make sense, catheterized, I think they meant to say. So I think they put a catheter in as number 16, and they're doing this to determine if what? Why would you do that?
I don't like any of those answers. I don't know.
So we wouldn't put a catheter in to determine if someone has an infection because we could actually cause them an infection by putting one in, right? So his 24-hour output is adequate. I mean, maybe. Trauma has occurred. Well, you could cause trauma by putting one in. So I don't think it's either one of these two. So I would be between B and D,
Yeah.
right? So typically, like we have, bladder scanners anymore. So you really don't need to check residual this way. So what do you guys think?
My vote is B because, yeah, like you said, they have bladder scanners.
Okay, and then I think this is the last one of these. So a staff nurse who is promoted to assistant nurse manager may feel comfortable initially when supervising her former peers. She can best decrease this discomfort by, anyone have a guess?
Well, it's not C because it's not therapeutic because you're telling the staff. And I don't think writing down everything is going to help either. B to me, but I guess D because it says private conference, and I think that's the key. Evaluating the clinical performance of each staff nurse, and well, that's evaluating them. I guess discussions. I'll go with B. Sorry.
You're right. So this is just saying changes must be planned thoroughly and should be based on the need to improve conditions, not just for the sake of change. Yeah, so that makes sense. So anyway, that's kind of how this goes. So if you guys want to come in here and do some, so when you're doing it, if you hit practice, it'll show you rationales for things and you can kind of just go through and do so many. The other thing in here, let me show you this real quick. So down towards the bottom, after you get through all of this other junk at the top. So like this is how it starts out. So it has some test taking strategies here. So that's always helpful, you know. Then they have a test bank of just basic RN NCLEX type questions. So, you know, they give you all these different ones. They have research questions. They have select all that apply. So like if you really have a hard time with those, you might want to get in here and just try some of them and see if you can get it down. And then they have prioritization and delegation and assignment questions. Those are kind of good to do sometimes just to get you, you know, into the right mindset of how to look at it and answer it right. They got ABG ones here, nurse leadership and management, pharmacology, dosage calculation. Here's our funds one. So see, there's quite a few of these. So you guys can come in here and do some more if you want. So you can, you know, take your pick of how many you want to do. But then this is what I want to show you here. So when you get your printout from your fundamentals proctored, you know how they break it up into different categories. It's like basic comfort and care, health promotion and maintenance, that type of stuff. You could come in here and do some on the topic that you had a hard time with last time you took it, you know? So I don't know, trying to think of one that everyone usually has a hard time with. Let me see. Now let's look at this one for a second. I won't do all of these with you, but let's just look at it for a minute. Okay, so this one is questions in health promotion and maintenance. So some of the things they have in here, what equipment would be necessary to complete an evaluation of cranial nerves 9 and 10?
Hold on, I'm doing the mnemonic in my head. It's the vagal nerve, right?
Okay,
Sorry, I was doing the whole mnemonic in my head to get to 9 and 10.
that's okay.
Um, so probably D, maybe. Wait, hold on. Yeah, I don't know. I know it's like the vagus nerve, and then
See, go with your first instinct, Brandon.
oh, hey, okay.
All right, so this is some of the kind of stuff that's in here. They got which technique would be best in caring for a client following receiving a diagnosis of stage 4 tumor in the brain. This one, you have an 8.5 pound, 6 ounce infant delivered to a diabetic mother. Which nursing intervention would be implemented when the neonate becomes jittery and lethargic? Then we've got what question would be most important to ask a male client who is in for a digital rectal exam? The nurse assesses a prolonged late deceleration in the fetal heart rate when the client's receiving oxytocin IV to stimulate labor. The priority nursing intervention would be. So this is the type of stuff that's in here. So it's a little bit of a mix of different things. So anyway, you can kind of go through there and see what you have an issue with and what you don't. And maybe you can, focus more on things that you had a hard time with last time you took it. So don't forget, not only should you be looking at your last printout from when you took the fundamentals proctored, to focus on those things, but you should also be doing practice questions. So in ATI, you can do Learning System RN. There are fundamentals questions in there. There's practice ones and final ones. So you could do those. You could always redo your fundamentals A and B, practice assessments. You could do that if you wanted. You see all of these questions in here that you could do. To me, I think after you look through your book and look at certain things that you don't feel real good about, I think the practice questions are the way to go. So if you can really, focus on that, that should help you quite a bit. Always in the future, after this one, every time in every class, if you have a proctored exam, you need to be kind of looking at it the same way. So like if you do a practice, A or a practice B, really start focusing on the things that you don't know so that you can get better for the next time you take it. You have to take these proctor tests really seriously because they, count towards your grade. Anyone had any other things that they've done that you feel like it's helping you with your fundamental stuff?
There's actually a playlist on YouTube. Let me see if I can figure out what it is real quick.
If you find it, post a link in the chat.
Okay. Let me see. So
Is it the one I told you about?
actually Ashley found it. It's
Okay.
Level Up RN, and it's a nursing fundamentals playlist, and she kind of breaks down different things, which is really nice. Let me see if I can find it on my laptop to where I can post it.
You might even be able to share it. You know how to share things on here like I do?
Yeah.
You could try that if you want. See if you can share your screen.
Okay. So it said host disabled attendee screen sharing. So you might have to fix something on the settings to where we can share a screen as well.
Or you can post a link and Miss Silk can open it up and share her screen.
Oh, hold on.
Okay.
Hold on. Let me see if this works. Now try.
Yep. Okay. Mm.
There really is a lot of stuff on YouTube that's really helpful if you just look, if you just type in, nursing fundamentals Proctor, there's all kinds of stuff that comes up.
So this is the playlist. There's 24 different little videos. Oops. So down at the side here, it'll show like the different videos that she has in the playlist. And it kind of just
Nurses are in high demand.
It kind of just breaks everything down. So if you just type in nursing fundamentals level up RN, it should be the first thing that pops up is her playlist.
Well, that's good. Yeah, there's a lot of stuff in here. You just have to look for it. So if you guys spend some time doing this, I think you'll be good on Thursday. If anything, the littlest thing I want you guys to accomplish is just to do better than you did last time you took it, and even if it's only a little bit, that's better than nothing. I want you to see an improvement. So, work hard so you can do that. Is there anything else about fundamentals that you feel like you need me to talk about or go over? And just like, don't forget about like certain skills and stuff like that. Cause fundamentals is mainly skill everything, but it's not all that either. So it has other stuff that's kind of important that you wouldn't think about. So just make sure you're looking at all of that. Okay, so if no one has any other thoughts or questions about that, we'll go ahead and talk a little bit about the final, if that's okay. We good?
Yes.
Okay. All right, so for the final. So the first 20 questions of the final are going to be about the new stuff that we talked about, with the blood disorders. So there's something specific about hemostasis on here. What's it mean to have hemostasis? All I'm talking about is, like, say you got a cut on your arm and you started bleeding. What does your body do to get that to stop bleeding? That's the process of hemostasis. What happens?
So then clotting.
Yeah, so what's the steps there? What happens?
I mean, like, I know there's swelling and there's something like fibrin. And then, like, I don't remember.
Okay, so just, you know that you're going to have a question on that now, so make sure you review that, okay? So hemostasis, how does your blood, what happens when you start bleeding to get your blood to clot, to get that to quit? So there's a question about that. And then there's some questions about blood transfusions. So like, here's one about, like, I'm looking at it right now here. So it says the nurse is caring for a client receiving a transfusion and notes that 15 minutes after the infusion of these packed red blood cells, the client's having difficulty breathing and complains of chest tightness. What is your most important thing to do once you see that happening?
Wouldn't you stop the infusion?
For sure. Yes, definitely. So without, like some of the other options are, oh, I'm going to call the healthcare provider. Well, sure, you would do that, but your first priority is always going to be for your patient. You want to make sure your patient's safe. So you're going to stop that transfusion because obviously there's something wrong there, right? And one of the other things is remove their IV access. Why would you do that? Why would you take their IV out completely? That makes no sense. And then assess the client's chest sounds and vital signs. Well, yeah, you're going to want to do that soon as well. You would stop the IV, blood transfusion first, and then assess, and then you would call. Okay. Do you guys remember when I talked about vitamin B12 deficiency? What's one thing that can cause that? Remember, this was like pernicious anemia.
Maybe not eating certain foods. Don't you get B12 in proteins?
Okay,
So, I don't know. I'm thinking.
that's okay.
You saying what causes a deficiency of B12?
Yeah, what can cause it? There's a lot of different types of things that can cause it, but just name some. And Brandon, what did you just say about protein?
I mean, doesn't like fish and chicken and meat and doesn't it have B12? I think like protein turns to B12, or you get B12 from. I think there's something related. Okay.
Yes. So do you remember when we talked about this, I said people who are vegans would be at risk for this because they don't get any of that protein from, meats, because they don't eat meats. Okay. All right. Other stuff that is in here. Before you transfuse a unit of blood to someone, what's one of the things you need to do first?
You gotta verify with another nurse.
What else?
Check their blood type.
Okay. What else?
Get a basic set of vitals.
All right. Yeah.
You have IV fluids ready to go next to the blood.
Okay. Anything else?
Gotta get that different Y tubing out.
Okay. What about a consent?
Yeah, consent form.
Yep, they all need consent.
Now, is it okay to just do a verbal consent, or do you have to have a written consent?
Written.
Always written, right? Okay. There's one on here about, just trying to read it real quick. There's one on here about someone has like an irregular heart rhythm. They have AFib, and their primary provider put them on Coumadin or warfarin. So it says, when assessing the therapeutic response of this medication, what is the nurse's most appropriate action? So what lab would you be looking for to assess an appropriate response of Coumadin?
INR, right?
Yeah, yeah. Okay, how long is a bag of blood allowed to be hanging for?
4 hours.
Yes. So if you had a bag of blood hanging then, and that 4 hours was done, what should you do with the rest of the blood?
Just dispose of it, right?
Yes. So you never want to just, like, even if you just have a little bit left, you don't want to infuse it. You just stop it right at that 4-hour mark and you get rid of it. All right, if I said someone had an acute hemolytic reaction, you remember there's different types of blood transfusion reactions. If I said acute hemolytic, what kinds of signs and symptoms do you think of? No one has a guess?
Could you repeat the question?
If you have an acute hemolytic reaction, which is a type of blood reaction, what would be a sign and symptom of that?
Fever.
Chills,
Back pain.
It's
breathing
back pain.
issues, right?
Back
Oh,
pain.
okay.
Back pain. So what's it mean if you have an acute hemolytic reaction? What's happening? So typically, like if I donate blood, I'm A positive. So if I donate blood to be transfused into someone else, the blood bank takes it and they're like, okay, she's type A. They type my blood. And then when someone else needs blood, you know, it comes with this little paper and it has all the information on it when they send it up to the floor, right? So if someone has a hemolytic reaction, usually it's going to be because there's the wrong type of blood that they're getting. So there was some kind of accident where someone gave someone the wrong blood or something like that. Or maybe the label was wrong on the unit of blood or something, and it caused them to have this reaction. So it has to do with your antibodies and stuff. Does that make sense? Yes, no?
Yes.
Okay. Okay, so we didn't really talk about this a ton when I talked about this stuff, but there's other types of blood products that you can transfuse, you know? So we have platelets and plasma, all these different things, right? So when you are transfusing another type of blood product, you are going to do it the same way. You're going to get the same type of blood tubing. You're going to do the same type of everything. You know, you're going to get your vitals first. You'll get them the same amount of time that you would if you were transfusing a unit of blood. So the only thing that's really different with these is how fast you can run them. So there's a specific question about, I think it's plasma in here. So how fast can you run some of these other blood products? So with plasma, you can actually do it as fast as you want. So you can like run it in almost wide open as long as the patient tolerates it okay. So it's not like, you know, packed red blood cells where you have to do it slower. They can actually tolerate this better. What's it mean if someone has thrombocytopenia?
They don't clot, or they clot too much. Something with clotting, I think. I'm totally not Googling it right now.
All thrombocytopenia means is that you don't have a good amount of platelets. Your platelets are low. That's what that
Okay.
means. So you're not producing enough platelets. Okay, which type of anemia was it that with that kind of anemia, this person has pica, where they like to eat weird things? Do you remember which kind of anemia that went with? It said like they like to eat ice chips and clay and like.
Oh, iron deficiency anemia.
Yeah, yeah. Okay, so if you have a low platelet level, we already said that's thrombocytopenia. What would be another thing that sometimes you might see that goes along with a low platelet level, another sign and symptom?
Is petechiae one of them?
Yes, you're correct. You're right. So remember, petechiae are just those little like red dots that you have all over you. It's like little, I guess, splotches of blood under your skin, but they can look different on different people. But yeah, that's what it is. It's petechiae. Okay, so if you had to suggest some type of foods that would be high in iron, what would you say?
Meat, right? Like beef and stuff like that.
Okay,
Egg yolks,
okay,
greens, tuna, potatoes,
okay. There you go.
fish.
Okay, so I don't know if you guys remember me saying this, but when someone has end-stage kidney disease, they are anemic usually a lot. So they usually have a low hemoglobin and hematocrit just because of what's going on with their kidneys. They aren't making enough. So one of the medications that they give to help with that is called epoetin alpha. So EPO-ETIN, epoetin alpha, ALFA. So what that medication does, they'll give it when they're in dialysis, and what it does is it helps produce more red blood cells. Okay, what do you remember about sickle cell, you guys?
It's usually genetic. The blood cells are shaped like sickles, so they can't transport as much oxygen and
Okay.
things like that, and it's very painful.
Okay.
Um,
And you can be a carrier, or you can have, a full-blown crisis at times. So when you have a crisis, what are some of the things that might cause that to happen?
Clots, like they get stuck, um, and they cause like TIAs and things like that, maybe.
Okay. Like if you were the nurse taking care of someone that has sickle cell and you're trying to teach them about ways that they can prevent having another crisis, what would be some things you would be telling them?
You would tell them about to stay hydrated and about altitudes,
Okay.
like flying and climbing. Try to avoid a lot of stress.
Definitely. And
What Brandy said.
yeah. What about cold temperatures?
Yeah, they shouldn't be in cold temperatures. No swimming in cold water and stuff. It leads to crisis. No strenuous exercise.
Yeah.
Why no cold temperature for sickle cell?
Well, I mean, if you think about it, if they already don't have enough oxygen in their blood and they have the cold temperatures, what does the cold do to your blood?
Oh,
Constricts,
yeah, constricts. Okay, that makes sense.
right?
Thank you.
Uh-huh. All right. And then what do you guys remember about DIC?
It's clotting of the blood in your veins, right?
It
So,
always has yeah, it's intravascular coagulation. There's always a reason for it. It's an underlying cause. Something else makes it happen.
yes. Always. So it's not like something that you say, "Oh, I'm worried this person has DIC." It's like a complication of something else. Always. So when this, like, say this person is in ICU and they're really sick, like they have septic shock or something like that, they would be at risk for this because when you have shock, especially like septic shock, you're what's happening is you have this systemic inflammatory response that happens in your body, and you are kind of going down this cascade of things happening, and you're starting to get a high temperature, you're getting a blood pressure that's out of control, and all of these things kind of get a little bit worse, and it puts you into septic shock. So when you have this, you're going to be worried that this person is not going to have good blood flow to their organs, because when you're in shock, you're, like I said, your blood pressure is really low, and you're not getting that. So with DIC, what happens is you get the clotting cascade starts to happen. So inside your vessels, you start clotting like uncontrollably. And so you use up all of your clotting factors over time. Like you just keep clotting, all these little clots keep forming all in your blood vessels. And so it's making it even worse. So if I already have septic shock and now I have DIC, that's making it worse. I'm not getting any blood flow through because I'm having all these clots everywhere. So your body is just clotting uncontrollably until you use up all of your clotting factors, which I know it seems weird to think about that you wouldn't have any ability to clot anymore after a while, but you use it all up. So now after that, now you go from one extreme to the other. So now instead of clotting, now I'm bleeding uncontrollably. And so this person is at really high risk of death at this point. So if you don't catch this quick and try and do something about it fast, it's really hard to get them to come back from that. So some of the things that can cause DIC would be what?
Problems from birth.
Yeah, believe it or not, I mean, you probably have seen this on TV shows before where a mom goes in to give birth and all of a sudden they have this complication and she's bleeding uncontrollably and they can't get it to stop. That's DIC. What else did we say that could cause that?
Cancer.
Cancer.
I think you mentioned, I'm not sure, but I think you said hepatitis.
Okay. And then sepsis, of course, like we just talked about. You have to be pretty sick or have something else going on that causes this to happen. All right. And then once this does happen and you try to treat it, it depends on what stage of this they're in. So if they're in the early stages where they're just clotting a lot, what would you give for that?
Blood thinners like warfarin, Coumadin, stuff like that.
Yeah, you would give anticoagulants, so probably heparin. So then once they get to the point where they're just bleeding uncontrollably, what are you going to do for that?
I mean, at that point, you'd give them coagulants.
Well, I see
Sorry.
what you're saying, but you're going to replace what they're losing. So they're losing blood, so you're going to give blood. You're going to give fluids. You're going to give plasma, whatever. You're going to give all of that, so that helps. So yeah. So on the test, there's a couple of questions about DIC. One of them is mainly about cause. The other one has to do with like a nursing diagnosis for this. And like, that's the basic gist of the type of questions I'm going to ask about that first stuff. That's the first 20. And then we start getting into some other stuff that we've done before. So then there's stuff about dehydration, like who would be at greatest risk. And then there's stuff about, if you're treating someone for dehydration and someone makes a statement, what would make you say that, oh yeah, they understand my teaching, And then there's stuff about there's a lot of food kind of things. So like this one's about someone's on a restricted sodium diet. So which food choices for lunch indicates that the patient understood the teaching right? So you would pick something that was low in sodium, There is something about hypocalcemia. So hypocalcemia, so low calcium. It says, what interventions would you include in their care plan? So if someone has low calcium, what kinds of things would we be doing for them? And what are they at risk for if they have low calcium?
Aren't they at risk for falls?
Yeah. And probably maybe fracture too, because they have low calcium. So you have to think about safety kinds of things for interventions for that. A lot of times you'll see questions that have stuff about moving them with the draw sheet and stuff like that, or repositioning them or whatever, that those would be correct because they're all about that safety and not you're worried about fracturing their bones because they don't have enough calcium. There's another one in here that has stuff to do with ABGs, which I don't know how comfortable you guys felt about all of that, but there's a couple of questions that have to do with that where you look at the numbers and you have to figure out something from that. So like this one is talking about, it gives you the numbers and it says which manifestation does the nurse identify as an example of the patient's compensation mechanism. So basically, if you figure out what kind of ABG this is, whether it's respiratory acidosis, metabolic acidosis, whatever, then you have to say, okay, what thing would be kicking in to compensate for that, to get the pH back to normal? So it's always the opposite, So like if this was respiratory, maybe my kidneys would kick in to fix this, If this was metabolic, maybe my respiratory would kick in to fix this. And then the other one is, again, it'll show you like an ABG with the numbers, and it says which clinical situation does the nurse correlate with these values? So what is it telling you is going on? Like what could have caused it? There's probably, there's 3 of those. All right, then there's something about a central line. So you need to know a little bit about central lines and basics about how to take care of those. There's something about a PICC line here. Something about a peripheral IV site. Then there's a specific question about central line bloodstream infection, like how you could, prevent that from happening. There's another question on a PICC line about, you remember how we said with central lines, you always use a 10 cc syringe to flush with, you never use anything smaller. Why was that?
Something about like reducing the pressure.
Yeah, so if you did like a 3 cc or a 5 cc syringe, it would cause increased pressure there and it could cause that catheter to rupture and it could cause a big mess. So you need to use, the 10 cc every time, for safety purposes. So this has to do with that. All right, and then this is like a pre-op question, and it talks about what would be something that you would want to relay to the surgical team, like an important finding in your assessment pre-op that would be something they need to know about? So can you guys think of anything that you would be wanting to tell the surgical team?
If you find out maybe they're allergic to medications or allergies, something like that.
Okay. What else?
Oh, if it's their first surgery, I think I remember that from exam 1, because if they've never had a surgery before, they might be at risk for that serious condition we learned about.
Hypertensive emergency?
Yes, I don't know. It was that condition when someone's like muscular and they can have that
Oh, yeah,
disease.
yeah. What else?
If they use any herbs and remedies like that.
Oh, I'm sorry, I didn't hear what you said.
If they use like those like herbs and stuff.
Yeah, definitely. Yeah, because a lot of people, when you talk to people at a hospital setting, you would be shocked at what they think is an actual medicine and what they don't think is a medicine. Like you'll say, okay, give me your list of meds, and they'll give you like, oh yeah, I take lisinopril, I take, diabeta, I take this and that. But then they also take herbs and they don't tell you because they don't think it's a medication. So they don't think it's important to talk about, but it is. And that's definitely something that a surgical team would need to know, because most of those things can cause all kinds of trouble for you if you're having surgery. It can cause increased bleeding. You can have interactions with some of the anesthetics and stuff. Like all kinds of things can happen. So that's definitely something. And then think of some things. I don't know if you remember us talking about this, but in pre-op how you do vitals with them, and say they have a really crazy blood pressure, it's out of control, or maybe they have a temperature. Well, that could be something that could delay the surgery, so that would be something to tell them about. If this person was a drinker, you would want to know about that. Anything like that is what we're getting at here. And then there's another pre-op question that shows you some labs, and it says which one of these would warrant immediate communication with the surgical team. And then here's something about informed consent. So what's your responsibility as a nurse with informed consent?
Just to be a witness that it was signed.
Yeah, so if you're going in there to get it signed and the patient says, oh, well, I heard that this, and this could happen with the surgery. Is that true? You're not supposed to comment about any of that, because that's not for you to do. It's for the surgeon to do. So if they still have questions, you would get the surgeon over there to talk to them about it. Let's see. All right, so if someone, if you're taking care of someone post-op and they have an abdominal drain, what assessment by the nurse would indicate that the goals for the priority patient problems related to the drain are being met? So meaning that, okay, I have a drain after surgery. How do I know that that's working like it should? So typically, say we have a Jackson Pratt drain or something like that, maybe that first day it drains quite a bit, but each consecutive day after that, it should be less and less. So that's kind of what that's getting at. So you want to see less drainage. You don't want to see any weird colors. You don't want the drain to accidentally come out or anything crazy like that, right? You don't want it to look infected at the site. Going back to pre-op for a second. So, you know how we said a lot of people are at risk for stress ulcers when they have surgery, or even after surgery and they're in the ICU or whatever. So this one's talking about someone is given ranitidine, which is Zantac, which that's a H2 receptor blocker. So the patient's like, why are you giving me this drug? I don't have any ulcers or anything. So what would you say? It's because of stress ulcers. So, You know, it's going to prevent you from getting ulcers from stress for this of the surgery. What would you do if you were in surgery, intra-op, and you saw someone break sterile technique?
Wouldn't you just inform them that they broke the sterile field?
Yes, you would say, hey, I noticed that you broke the sterile field. We need to reset things up so that, you know, we can protect the patient. Yeah, you're right. All right, so moderate sedation. What is moderate sedation, you guys?
That's where you're knocked out, basically. Right?
Another name for moderate sedation is conscious sedation.
Oh, sorry. I was thinking general. Never mind.
So remember, moderate or conscious sedation is something that you would do for a lot of different procedures, actually. Like, you know, you could do this for cardioversions. You could do this for someone who's getting a chest tube placed, any type of endoscopy kind of a procedure, like a colonoscopy, an EGD, that ERCP, any of those. That's like a moderate sedation type of a thing. So you give them medicine and it makes them kind of go out, but not to the point where they're like general. General, you can't wake them up whatsoever. They can't protect their airway, all that kind of stuff. With moderate or conscious sedation, you have them on oxygen. Usually they're breathing fine on their own. They're not having any issues. Doesn't mean that they can't eventually have issues with their airway, because they can if they're under for too long. But yeah, generally you can wake them up really easily. So if I was under and you were taking care of me, if you shook me, I would wake up from this. So you can come out of it pretty quickly. So if you had someone who had moderate sedation, and like say, I don't know, they came in to have an ERCP, and so you were working in the recovery room, and then this person wants to, you know, go home, what would you do? Are they allowed to just get up and leave and drive themselves home?
They'd have to pass the Aldrete scale.
Right. And so one of the things that we would have to do, you know, like especially if this was, you know, something where like they had an EGD or something, typically if they, you know, to put that scope down your throat, you also are getting sprayed in your throat with this medicine that numbs everything. And so you need to make sure that they have a gag reflex that returns and that they're with it enough to, you know, get your discharge instructions. They have to have someone there with them to drive them home. They can't drive themselves, you know. So all of those things kind of have to be in place. They have to be able to have decent vital signs, be able to breathe well, follow directions, all of those things. Okay. What's one of the first things you would do when you receive someone from the recovery room with that patient?
Check their airway.
Okay, but I like what you're thinking, but before that even, what would you do?
Get report.
They just roll into the recovery room. You would get report, and then what would you do? It's really simple. You're just forgetting.
Vitals?
You're hooking them up to everything. So you're going to hook them up to the cardiac monitor. If they're on a ventilator, you make sure all of that's hooked up okay. If they have a drain, you're going to check that drain and make sure everything is where it needs to be. So you're hooking them up to everything, basically. Post-op, if someone vomits, what are we most worried about after they vomit?
Be aspiration.
Yep.
Yeah, it would be aspiration. So what would be one of the things you would check after this happens?
Their lungs.
Yeah, so you're going to listen to their lungs. There's a question, something about evisceration, or, dehiscence and evisceration. There's a question on that. There's something about hypothermia, like someone in recovery room may have hypothermia. What's something that you would see as an assessment finding that goes along with that? Then this gets into a little bit about orthopedic stuff. So it talks about skeletal traction. Remember with traction, we want to make sure that nothing is obstructing it, that the weights are hanging freely. You never want to take the weight off at all. That always would stay on. You keep them aligned in the bed, so make sure they're straight up and down in the bed and they're not all crooked or anything. Do you remember what type of patient would be more at risk for getting like a blood clot after surgery? When we talked about the orthopedic stuff, remember how we said there's certain types of surgeries that make you more at risk than others?
What do you mean as far as like the hip replacements and stuff like that?
Yeah, so remember we said any long bone fractures, like, if it's a pelvic fracture, if it's like your femur or something along those lines, you're going to be more at risk for blood clots. Also, and this has nothing to do with the orthopedics, but just FYI, other types of surgeries that are always more at risk for that would be any kind of gynecologic surgeries. So people who have hysterectomies or things like that, they're at risk. Yeah, so in this particular question, it's going to be more geared toward orthopedics. So you'll see like the fracture or something in there, and that'll say, oh yeah. But yeah, so anything along those lines, that would be, who's going to be more at risk. And typically it's usually an older adult more so than a younger adult, And then just remember, we talked about amputations a little bit, and we said that if someone has, what am I trying to say? If they have phantom limb pain, we always treat that just like we would treat any other kind of pain. We take it seriously. It's an actual pain that they're having. So we wouldn't want to, minimize that whatsoever. We would want to treat it just like we would anyone else. Okay, so again, with skeletal traction, what's the purpose of it? I think this is a repeat question from what you had before.
It helps to realign your bones.
Yes, it does. So if we didn't do this type of traction, your bones aren't going to get back into alignment, and then they're going to heal funny and you're going to have problems. So we do the traction so that we can get the bones back into the right alignment, and then hopefully they'll start to heal the right way. Let's see. Do you remember what a vertebroplasty is? So back when we talked about osteoporosis, we talked about, how osteoporosis is basically your bones aren't very strong. You don't have that big matrix in your bones. So they're very porous and they're weak. So they can fracture really easily. So one of the places that you fracture quite often with osteoporosis is your back. And so a vertebroplasty is where they do a procedure where they put cement in your vertebral column to get that set so that that helps fix that fracture. So remember, with that procedure, you cannot just like get up really quickly after that happens. So when they come back to the floor, you're supposed to keep them supine, you know, in a flat position, and they can't get up for a while because you have to have time for that cement to set so it's going to work. So just remember that, because for this question, it's going to ask you about a vertebroplasty. In the one chapter of stuff that we talked about with oral and esophageal disorders and stuff, I believe we talked about, you know, like when we talked about oral cancers and things, we said, I'm pretty sure I gave you definitions for stomatitis, and I forget what the other one was at the top of the one page. So do you remember what stomatitis is, you guys?
Is that the bad? Is it bad breath?
No. This is something that a lot of people that have cancer will get, you know, like say they've had chemotherapy or something, and then they'll end up developing this. So what happens is, if you're looking at your mucous membranes inside your mouth, you'll have like the top layer of skin that will come off. So they'll have lots of little openings all over the inside of their mouth, and it'll be really sore and painful. So if you have that, and you also have dysphagia where you have trouble swallowing, you would want to do something about that for them so it feels better, but not cause them to aspirate, you know. So there is something called viscous lidocaine, which is really thick, and you could have them gargle with that and then spit it out, and that way they're not swallowing it. And that would help like numb up their mouth, so maybe they'd be able to take something in then. Because a lot of times when they have that, they're not able to like take in enough nutrition and they have problems. So viscous lidocaine is the thing for that. Okay, do you remember when we talked about hiatal hernia a little bit? So with a hiatal hernia, you have similar things that you would do for that with GERD. Like you'll have similar things you would do for it. So like, hey, I put my head of my bed up. I don't eat after a certain time at night. I stay away from certain foods. I try to lose weight, you know, all those things. Now, so you would do all of those things first, but then if that still didn't work and they were still having a lot of trouble, then they could do surgery for it. And it's called a Nissen fundoplication. So there's a question about that. So it says a patient scheduled to have a fundoplication. What statement by the patient indicates a need for a review of pre-op teaching? So the thing about this is this surgery is not necessarily a fix for this per se. You can actually get some of your symptoms back even after they do this surgery. So you have to be careful. You can't just eat whatever you want afterwards. You have to be eating like softer foods for a while and not go too crazy with the stuff that you eat. So just that you have stuff in your ATI book about this. I would read about it a little bit so you understand a little bit more about Nissen fundoplication. Okay, there is a question that is going to give you a bunch of information about a patient, And you have to look at all the information and decide what's going on, what the disorder is that's happening. And then by after you look at all that information and figure out what's going on, then you look at the options and you're like, oh, okay, this is what I would do for that. So there's a question like that. There's a little bit of stuff about peptic ulcer disease, something about H. pylori. Couple of things about medications. So I don't know if you remember talking about Carafate or Sucralfate. There's something about that, so I would look at that. There's a few things about a colostomy, like someone who has had, part of their colon taken out and they have a new colostomy. So I would just kind of review stuff about colostomies and like what's normal to see after they get it done, like what their stool should look like. There's something about appendicitis in here. Okay, with Crohn's disease. So remember when we talked about it, about it along with ulcerative colitis. We talked about both at the same time. They both have similar things that happen with them, but they also have differences too. So in this particular question, it's about Crohn's disease. And this person also has a draining fistula, which is a possible complication that you could have from Crohn's. So it says, which documentation would alert the nurse to urgently contact the provider for additional prescriptions? So it's going to give you some like different information in your options, and you have to be like, oh, that's not good. I'll call about that, So each one of these options is, something that is just like a piece of information that you have to decide which one's the worst thing, and you would use that. There's a little bit about diverticulitis in here. So someone has that, and just like basic teaching you would do with them about that. And then, we all know what a decent stoma is supposed to look like. So there's something, having to do with the stoma. So then we get into a little bit about liver stuff here. So here's a little bit about cirrhosis. So just remember, from that last test we just did, if you have a question that talks about cirrhosis, or if someone's newly diagnosed, they're not going to have as severe of symptoms as someone who has advanced cirrhosis or someone who's had it for a while. So pay attention to that kind of stuff in the question, because you're going to, you'll see differences. And then there's something about a bleeding esophageal varices. Something about lactulose. A little bit about hepatitis. It looks like I have something about A and B and C on here. There's something about gallbladder surgery. And then acute pancreatitis is on here. And then there is a little bit about the pancreatic enzyme replacement therapy. So if someone has to take those pills, typically they're like really big capsules. And there's a bunch of things that I said about those in my talk to you guys about that. But basically, you have to take those every time you eat because they help you digest things, you know, because you have your pancreatitis, you're having issues with digesting certain things. And so by taking this, like you would have stools that wouldn't have any fat in them because you take this, you know, because it's helping you digest. If you're not digesting things, you're going to see the fatty stools, that's steatorrhea. Other things about this, remember, like say you had a hard time swallowing those big capsules, you could open them up and then pour those little beads or whatever on food. But the thing is, you can't mix it with just anything because certain things will break down what's in there. So it has to be mixed with something that's acidic, like applesauce. Like you wouldn't be able to mix it with ice cream or pudding because that would break down, you know, those pancreatic enzymes. What's something that's important to do when you're giving a bolus feeding through a Dobhoff tube? What's important to do before you do that?
You verify the placement of the tube.
Okay. Everyone agree? No one wants to say anything? I feel like I'm talking to myself. No one's talking. There's a couple of things about gastric bypass. They're not to the extent of what we did on test 3. Like this one says, if someone just returned from having that, a gastric bypass surgery, what action by the nurse is priority? And then another one's talking about so a morbidly obese patient is admitted to a community hospital that does not typically care for bariatric sized patients. What action by the nurse is most appropriate? So there are, let's see, 2. There's probably a couple of, maybe 3 or 4 questions about pain. This one's about someone says that they've been saving their PRN analgesics until the pain is intense because their pain control has been inadequate. So what teaching should you do with them?
You always want to give pain medicine when their pain is lower because it's easier to treat.
Definitely.
And when someone's like an 8 or a 9, it's hard to bring that down.
Yeah.
Okay.
And then there's just a couple other ones about pain there. So they're just general like that last one I just talked about. Like this one says, someone who has a medical history that includes chronic fatigue and poorly controlled back pain, these medical diagnoses should alert the nurse to the possibility of what consequent health problem. So if you have chronic fatigue and chronic pain, what are you at risk for?
Like mental issues.
Depression.
Oh yeah.
Right. And I mean, it's understandable. Like you're living with this pain and this discomfort all this time and you're not getting anywhere with it. So yeah, it would be depressing. There's something about a PCA pump. So it says a client is receiving post-op morphine through a PCA pump, and the client's prescriptions specify an initial bolus dose. What is the nurse's priority assessment? So if you're giving morphine, what are you most worried about? What's something that can happen when you give morphine?
Their breathing can stop.
Yeah. So that's going to be something you're assessing for. You're assessing for respiratory depression. Because if I have to give this initial bolus dose, I'm giving more morphine in the beginning when I first set this pump up, then if they're not breathing really good, I'm not going to do that because I'm going to cause them to quit breathing, right? Actually, there's more pain questions than I thought. There's more than 3 or 4. But I don't think they're that bad, though. This one's talking about someone gets an opioid and an NSAID given together. What's the primary rationale for doing this? What did we say?
Is this the same question that was on a test already?
Could have been.
Wasn't it like pain is complex or something?
This is to achieve better pain control than with one medication alone.
Yeah, I think that is a repeat because I think that was the answer.
Some of these are funny. So an unlicensed nursing assistant reports to the nurse that a post-surgical client rates her pain as an 8 on a 0 to 10 scale. The nursing assistant tells the nurse that he thinks the client's exaggerating and does not need pain medication. What's the nurse's best response? And then this one here. So if you're giving pain medicine to an older adult, what do older adults do with pain medicine when you give them pain medicine? What can happen with them?
It stays in their body longer.
Yes. And what else could you possibly see happen when they get pain medicine?
I don't know.
They
I'm
can
trying
get
to think. I don't know.
confused,
Oh, okay.
right? They can get confused from it. So in this question, it says you're receiving an older adult client from the PACU. Part of the report has been passed on from the preoperative assessment where it was noted that the client has been agitated in the past following opioid administration. So this person gets confused and agitated after you give them an opioid. What principles should guide the nurse's management of the client's pain? So what do you think?
Give them lower doses maybe so they don't go crazy.
Yeah.
Okay.
So because we know that they can hold on to stuff for longer, like you guys were just saying, because of the way their body system works now, you would want to give them a smaller dose so that you still are treating their pain, but you're not going to make them all crazy from getting the med. And then if it still happened that way where they were still crazy when you gave them the lower dose, then maybe you would switch to some other type of pain medicine. You guys, what's the antidote for an opioid?
Narcan?
What's the other name for it?
Naloxone.
Yeah. Yeah. So there's a question about that. And then let's see, what's this one? So a nurse caring for an older adult client with osteoarthritis is reviewing the client's chart. The client is on a variety of medications prescribed by different care providers in the community. In light of the CUSIN competency of safety, what is the nurse most concerned about with this client? So if they're getting different medications from different places, what are you most concerned about?
Drug interactions.
Yeah. Exactly. All right, so then on your final, there's 2 math questions at the very end, and they're easy ones. So the one is about milliliters per hour. So remember, you're taking your volume divided by your milliliters per hour. Or actually, it's just telling you how long will it take it to completely infuse. It's a time one. So volume divided by the amount, 50 milliliters per hour. Okay, and then the next one, oh, they're both time ones. So you guys remember those, right? So basically both of these will just give you, hey, the doctor orders a certain amount of IV fluids to infuse at a rate of whatever, and then it says how long will it take it to complete. So you're just dividing, and then remember, if there is like if you have to figure out minutes, like say it comes to 13.33, like that one question we had. So you would take your 0.33, which is still repeating, but you take it to those 2 numbers. So 0.33 times 60. And then, whatever, I'm trying to remember what that was. I want to say it was like 19.8 or something. And so then you would round that to a whole number, and that would be your minutes. So 13 hours, 20 minutes. You guys remember that?
Yeah.
Okay. So that's all those 2 math questions are, so they shouldn't be bad. So I kind of just went through everything with you, so hopefully you feel a little bit better. I don't think it's too horrible. There's, some pain things at the end. So if you don't feel like you did really well on those pain questions that we had on the one test, maybe just review a little bit more about pain. So again, you could look in your ATI books, and then you could also look in your big book. There's a pain chapter in there. So I would look at that stuff to review.
Miss Shoop.
Yeah.
I just got a quick question about the VSIMs. What's our score have to be to pass it?
So for the VSIM itself, you're supposed to at least get a 76. Okay, so passing, like we say for tests,
Mm-hmm.
And then for the post-test that you take, that's supposed to be 100%.
Okay, I just my clinical instructor emailed me saying that I had to get an 80% or higher on the VSIMs, and I was trying to tell her that we were told. I thought it was a 75 or a 76, but she's saying 80%.
Which one is that?
Ms. Zellhart, she sent me an email.
Yeah,
saying
she
that
doesn't. You're fine. 76 is okay. I can email her and tell her that. Maybe she just doesn't realize.
Okay, thanks.
But yes, so I do want to say something about these VSIMs, because there's a ton of you who still are not done or even close. You guys, we have a week left here, and I have to finalize grades, so you can't be waiting until the last second to get these done. So I get that you're worried about these tests and stuff, and you're trying to study, which is great, but you need to get your other stuff done too. So, take a break from your studying and work on those and get those done. It's important. If you don't get those done and you're not complete, you can't pass the class. So, it's part of your clinical grade. So if you don't pass that, then you won't go forward. So you need to work on that stuff. If you're having a hard time getting in, or you're having a hard time with something, talk to your clinical instructor. That's what they're there for. And, for next term, we're going to continue doing this kind of stuff. So, get used to it. You have to get into it and understand what you're doing. So for our final, what did I tell you guys before for our final for a date and a time?
I have it written down as Monday the 27th. I don't know what time though. I just wrote it in my calendar that it was supposed to be on the 27th.
Do you want me to do Tuesday the 28th instead?
Me personally, I wouldn't mind, but go with the group.
I would prefer Tuesday as well, just to keep it in, because we've been doing school every Tuesday anyway.
Yeah. Is everyone else okay with Tuesday the 28th for your final?
I have a training for work that's all day Tuesday. I've already canceled it once. So, I mean, if everyone wants to do it Tuesday, that's fine, but I'm going to have to take it another time.
You can take it on Monday with me. That's fine. But
Okay.
everyone else can do Tuesday. Is that okay?
Yeah, that's fine with me.
Yeah, it's fine.
Adam, you just get with me an email and we'll figure out a time on Monday that you can take it.
Okay, that works.
All right. So I will post this officially on our page, our Canvas page, so everyone's aware. But let's say Tuesday, the 28th, we'll do our final. And I'll probably do it in the morning at 9. Now, for this Thursday, when we have class, I'll put, a Zoom announcement up, of course, for you guys to get in. But, we're doing this ATI thing, and I'm a little unsure about everything as well because I haven't done it yet. So we'll see. But I think that I'm probably going to have you guys all test at the same time this time, because with ATI, it's just a little bit different. I don't have as much control over what I'm doing as I would with our tests. So I think I'm going to try to do everyone all at one time. So is there a time that works for everyone on Thursday?
I'm free all day, so whatever other people decide, I'm up for anything.
Me too. It doesn't matter.
Is it okay if I stick with 9?
Yeah, that's fine with me.
Sure.
Okay. So that's probably what I'll do Thursday then. So just plan on 9 o'clock and, watch for your announcement for the Zoom. Okay. Any other questions or concerns?
Miss Silk, so you're not going to be a part of our proctored exam. Am I understanding that right?
No, I'll be there. I'll be in there. It's a different setup. So I can't have 3 million different groups go in and take it at the same time because it's at a set time.
Mm-hmm.
So,
and you're not proctoring it, right? It's going to be like ATI proctoring it. You're just going to be there cheering us on.
No, I think I'm proctoring it with you guys.
Oh.
Yeah, I have to look at all that stuff again to see how that goes. I have it all printed out. I just got to look at it. So, but yeah, I'll be there as well. So did you guys all watch that video I sent you about it?
Yeah, I did.
Okay.
Yep,
So
I already have the software installed.
I was confused because I thought it was something we were doing on our own without you because of those instructions. Like we're not using our same setup how we would do where you would view our screen. We're using something totally different.
Yeah, which I still can see your screen and all of that from my end, what I'm doing. So it's I don't know if you remember about taking the proctored before last time when you had your other class when we were on campus. So it's going to be very similar. Like we'll get in the same way to ATI. You'll find everything in the same spots. It's just a little different with how everyone's looking at your screen and stuff.
Okay, and that's scheduled for 9 o'clock on Thursday.
Correct.
Okay.
All right. I'm going to let you guys go if you guys don't have any more questions.
All right. Thanks, Miss Silk.
Thank you.
All right. Have a good rest of the day.
You too.